multiplier system, which generates a osmotic, hyperosmotic environment in the medullary interstitial fluid, and that sets up a gradient where we can pull water out of the collecting duct if we need to. We call that filtration is not particularly specific. It's based on size. So in normal circumstances, when your capillaries are working correctly, we will filter anything that is small enough to fit through. And this would include most things, but things that are too large are the red blood cells, the white blood cells, the platelets, and most proteins. Everything else gets filtered, it's small. The reabsorption is more specific, and often, at least in part, is requiring energy, ATP, for at least some of the steps. About 65% of what gets filtered gets reabsorbed right there in the proximal convoluted tubule. This would include the water and the sodium and the chloride, for instance. Some things get reabsorbed to a greater percentage in the proximal convoluted tubule. For instance, glucose normally gets 100% reabsorbed in the proximal convoluted tubule, and potassium gets about 90% reabsorbed in the proximal convoluted tubule. The loop of Henle reabsorbs another about 15% of the sodium, chloride, and water. So 65% in the proximal convoluted tubule of sodium, chloride, and water, and another 15% in the loop of Henle. All of that reabsorption happens essentially automatically with no regulation. The only regulation would be how much you filter, not really how much you reabsorb. The rest of the way, the distal convoluted tubule and the collecting duct, we can vary, we can change the amount of reabsorption. And much of this change is regulated by hormones. The two major hormones that are involved are aldosterone and antidiuretic hormone, or vasopressin as it's also known as. There's another hormone which is perhaps a little more minor role, and that's atrial natriuretic peptide that we'll mention as well. Therefore, we can vary the amount of reabsorption that takes place in the distal convoluted tubule and the collecting duct. And this, of course, is very important because we want to maintain normal homeostatic values. We filter, as you recall, about 180 liters per day, and we generally reabsorb most of that, about 99% of that, for water and sodium chloride stuff. For water, let's say, we reabsorb about 99% of that. So we only excrete in the urine about 1.5 liters, approximately. We need to excrete a minimum of 400 milliliters a day in order to get rid of excess waste and that kind of thing. So we can vary if we have too little plasma volume, or too low of blood pressure, too low of sodium, chloride, and water. We can reabsorb more water. If we have too high a plasma volume, too high a blood pressure, we can reabsorb less and allow less to go out in the urine. So when we look at this, let's take the first scenario here. If our plasma volume is too low, blood volume, plasma volume is too low, we'll have a reduced blood pressure, and this will be sensed by pressure receptors, so-called baroreceptors. These are located mostly in the aorta and the carotid arteries. And that will lead to the release from the posterior pituitary of ADH, or vasopressin. Remember, ADH is produced in the hypothalamus, but it's stored and secreted from the posterior pituitary. ADH, or vasopressin, will go and have its target cells on the cells of the collecting duct, and that will cause the insertion of aquaporins. And because we built up this hyperosmotic environment with the countercurrent multiplier system, we will draw water out of the collecting duct back into the water, into the body, and reabsorb it. We will increase water reabsorption. Less water will go in the urine, and we'll go back to a negative feedback to increase our plasma volume back to normal. Therefore, antidiuretic hormone has an antidiuresis effect. Well, what if we lose sodium in water, maybe due to diarrhea or something of that nature? Essentially, our blood volume will go down, our venous return will go down, our end-diastolic volume will go down, our stroke volume will go down, our cardiac output will go down, our pressure in the arterial system will go down. We'll stimulate sympathetic nerves, and we'll do something different. In this case, we will decrease our glomerular filtration rate. With antidiuretic hormone, we are reclaiming more of the water that we filtered and allowing less to go in the urine. If we change our glomerular filtration rate, we actually allow less water and sodium and chloride to be filtered, to be lost originally. Now, how can we decrease, let's say, our glomerular filtration rate? Well, just the fact that our blood pressure is going down could decrease because we'd have less pressure to filter. But we can also change the diameter of our afferent and or efferent arterioles. You remember that going into each glomerular capillary, there's about 1 million in each kidney, we have an afferent arteriole bringing blood to the glomerulus and an efferent arteriole taking blood away from it. If our plasma volume is too low, if our blood pressure is too low, we can constrict the incoming afferent arteriole, and or we can dilate the outgoing efferent arteriole, and that will lower the pressure in the glomerular capillary, and that will decrease our glomerular filtration rate. By decreasing our glomerular filtration rate, we will have less sodium in water filtered and less sodium in water excreted. So that's another way that we can reestablish homeostasis. In this case, again, our blood volume is going down, our blood pressure is going down. Of course, these mechanisms can work together. We could release ADH at the same time. What about aldosterone? Aldosterone works essentially by altering the reabsorption of sodium and chloride, which will affect the reabsorption of water. Aldosterone works predominantly on the distal convoluted tubules, a little bit on the very first part of the collecting duct. So let me say just a little bit more about that. ADH works primarily on the collecting duct. Aldosterone works primarily on the distal convoluted tubule, a little bit of the collecting duct. they work through different mechanisms. ADH causes the cells of the collecting duct to express more aquaporins, water channels, and the hyperosmotic gradient that has already been set up allows the force to pull the water out of the collecting duct and back into the body. Aldosterone works by increasing the sodium reabsorption. Chloride would follow because it's an anion being attracted to the cation of sodium. And water would follow that. So if we have a low blood volume, a low blood pressure, we can also stimulate aldosterone, which will act on the distal convoluted tubule to reabsorb more sodium, chloride, and water. If it's due to a low sodium, chloride, and or water concentration, it will tend to work through the angiotensin-aldosterone system. Blood pressure, blood volume falls. This will cause angiotensinogen to be converted to angiotensin 1 by the release of an enzyme from the kidneys called renin from the juxtaglomerular apparatus. Angiotensin 1 is then converted to angiotensin 2 by ACE, angiotensin converting enzyme. Angiotensin 2 is a mild vasoconstrictor, but it also will stimulate the release of aldosterone from the zona glomerulosa of the adrenal cortex. Aldosterone will go to the distal convoluted tubule predominantly and cause more reabsorption of sodium, chloride, and water, and that will raise our blood pressure back up. We talked about this with the cardiovascular system and how we could block a number of these steps if you had a patient with hypertension, high blood pressure, and you could inhibit, you could get an ACE inhibitor, for instance. Again, aldosterone, often this system would work along with an increased secretion of ADH, along with decreasing your glomerular filtration rate or increasing it as the needs may be. So they don't just work on their own in isolation, they often work together. This shows us some of that in this particular flow chart. If our plasma volume falls, we could increase the activity of the renal sympathetic nerves. That would constrict the afferent arteriole and decrease our glomerular filtration rate. We could also have, as our blood pressure is falling, baroreceptors. This could cause renin secretion, have a decrease in glomerular filtration rate, and we could have our renin-angiotensin-aldosterone system activated, as well as ADH, and then we could reabsorb more sodium, chloride, and water from the distal convoluted tubule, and ADH could cause the reabsorption of more water from the collecting duct. Notice ADH does not work through sodium and chloride. It works just by opening water channels, whereas aldosterone works through the reabsorption of sodium, chloride, and water. So there's a little bit different mechanism between the two. This shows this sort of whole flow chart. And the same things are shown here. Increase in sympathetic activity. Here's our renin-angiotensin-aldosterone system. Here's ADH. They can all work together to get us back into balance. What if our plasma volume is too high? Well, of course, if the plasma volume is too high, one thing we could do is secrete less ADH and less aldosterone. We could crank those things down. But we can also increase the secretion of another hormone that we briefly alluded to, which is called atrial natriuretic peptide, ANP for short. This comes from the heart, some of the atrial cells of the heart. This decreases plasma aldosterone, but it also has a direct effect. Notice it causes afferent arterial dilation, so you're going to increase your glomerular filtration rate. And working through decreased aldosterone, it decreases sodium reabsorption, chloride reabsorption, and water reabsorption. Therefore, more sodium, chloride, and water are excreted, and you are bringing your plasma volume back into homeostasis. You're decreasing. Again, if you have too much water, too high of water volume, too high of blood pressure, you could decrease your ADH or vasopressin secretion so that less water is reabsorbed, more goes out in the urine, and eventually that brings us back into homeostasis. If you lose a lot of sodium, chloride, and water through sweating, again, you'll have your reflexes to bring it back. Renin-angiotensin system decreases glomerular filtration rate, ADH, all of this bringing you back into balance. In addition to all that, we can monitor our thirst, our water intake. If our plasma volume goes down, our osmoreceptors will detect a greater solute concentration, and we'll stimulate thirst from the hypothalamus. That's where it's located. Dry mouth, all that. Probably angiotensin 2 may stimulate thirst, but we don't have definitive evidence of that. And then the other side is if you're having a bunch of water in your gastrointestinal tract, your stomach and the like, that can inhibit thirst. Say, oh, I've got plenty of water coming. So thirst is also part of the fixing. How do you feel? Feel all right? One thing to keep in mind as you're preparing for the test and doing the test, remember that whatever is happening to the body in terms of water and solute, the opposite is happening in the urine. So if you are sending more water out into the urine, your internal environment is getting more concentrated, higher solute. If you're sending less water in the urine, retaining more, you're becoming more dilute in your internal environment. It's just opposite. So that makes intuitive sense, but just if you keep that inverse relationship in mind, that might be helpful as you're trying to evaluate things. All right, well, a little bit more about potassium regulation. Potassium is freely filtered. It's small enough to get filtered right through. But about 90% of potassium is reabsorbed in the proximal convoluted tubule. Interestingly enough, we regulate our potassium values in our internal environment by secretion. In other words, we reabsorb pretty much automatically most of what we filter. So if we are now getting too high of extracellular potassium, what we could term as hyperkalemia, because potassium, remember the K is kalium in Latin. If we have too high of potassium, hypokalemia, then we want to get rid of something, and we can do that by secretion in the distal convoluted tubule. What triggers an increase in potassium secretion and ultimately excretion? Aldosterone again. But it's a direct effect. What do I mean by that? Sodium, it's an indirect effect. You have to go through the renin-angiotensin-aldosterone system, whereas if your potassium level is too high, you directly cause aldosterone to be secreted from the zona glomerulosa of the adrenal cortex. It's a direct effect. And so that's how it would work. Now, just to remind you that potassium is mostly inside of the cells, intracellular. We do have normal concentrations outside of the cells in the extracellular fluid. It's just not near as high as sodium and chloride, for instance. And so we still need to maintain a normal extracellular value of potassium in our internal environment, if you will, in our blood. Potassium levels, in fact, are very critical for the normal functioning of the heart and the nervous system too, but the heart is especially susceptible to having hyperkalemia or hypokalemia. And so if there is an excess, we could secrete more aldosterone, and if there's too little, we could secrete less aldosterone. This shows this direct effect. Too much potassium directly causes increased aldosterone, causes potassium to be secreted and excreted. Here it is again. Plasma volume, sodium and chloride, that would work through the renin-angiotensin-aldosterone system. Plasma potassium, or internal environment potassium, works directly increasing or decreasing aldosterone. And this is just a summary of all the main functions of each of the different parts of the nephron. Well, all right, what about diuretics? A diuretic, we know, makes you pee more. It makes us lose water into the urine. It lowers our blood volume. Why would we need a diuretic? Well, we'll get into that in just a minute. But we have some things in our food or drink which are natural diuretics, make us pee more. Alcohol is one. Alcohol inhibits the release of ADH, antidiuretic hormone. So you don't release as much ADH. That means you pee more because you don't have as much ADH there to reclaim that filtered water in the collecting duct. So alcohol is a fairly mild diuretic. Caffeine is even a more mild diuretic. It's a very mild diuretic, but it does make you pee a little bit more, but not a huge amount. So those are some things in our food or drink in this case, that are natural diuretics. We can also have osmotic diuresis. We talked about that with diabetes. If we filter too much glucose because we have hyperglycemia, so that we cannot reabsorb all the glucose from the nephrons. That glucose is a solute, and it holds water in the nephron, and we pee out more water that way. That's why we get dehydrated with untreated diabetes, because it is pulling the water out. That's an osmotic diuretic. Well, why would you give a patient a diuretic? The most common reason is they have too high a blood pressure, or they have congestive heart failure or something like that. You're trying to lower the workload of the heart if they have congestive or a weak heart. And you may be trying to lower the blood volume and the blood pressure if they have hypertension. Because diuretics have fewer side effects than some of the other hypertensive drugs, if you're going to use a medication to try to control blood pressure, for instance, a diuretic may be one of the first things that are prescribed, and then you could add in other things as needed. The most common diuretic is Lasix. This acts on the loop of Henle. The reason it's so effective is it lessens the hyperosmotic concentration that you build up in the medulla. You decrease the countercurrent multiplier system. And so that means there's not as much solute to pull water out of the collecting duct in the presence of ADH. There's a problem with these so-called loop diuretics like Lasix, however. And the problem is they can deplete your potassium. They don't spare your potassium. And because of that, most people that are on these loop diuretics, the ones that affect the loop of Henle, in other words, also need to take potassium supplements. So if you're on that kind of a diuretic, you probably need to take potassium. There are a couple of other diuretics which are not quite as effective as diuretics. These are listed here and here. And they can be sparing potassium. And so sometimes they would be used. But again, the most common is, because they're more effective, is to give a loop diuretic and then just to give potassium supplementation as well. So that would be a diuretic and why you'd want to use that. All right, next we have acid-base balance. When we look at acid-base balance, we know that it's critical to maintain our internal environment within a fairly narrow range of pH, maybe 7.2 to 7.4. There are parts of the body where we can have a much different pH, like the stomach could be 2 or even 1.5 pH. But in our internal environment, meaning our blood and our interstitial fluid, having that low pH would be disastrous. We would die very quickly. We need to maintain this pH, 7.2 to 7.4 approximately, for many reasons, but one of the primary reasons is our protein enzymes could be denatured at an incorrect pH. And if they're denatured, then they're not going to work properly.
How do you test if somebody has like a certain blood pH? Is there like a simple test you can do, or
You can just do a blood test and then check the pH. You can even use like a pH meter or something like that and test for it. Fortunately, that's one of the easier things to test, because you can just do a blood sample and test it. You could probably even do it with a prick instead of taking a whole
you know, like this is probably gonna sound stupid, but like, you know, hot tubs, how they have those like pH sticks
Right.
where you put it in and they like say they go a certain color, could you like do something like that? Like,
Yeah, I think that would, you may lose a little accuracy with those, but that's basically you're using you do that in the lab like in chemistry, right? You use pH paper and you test it and it changes color, you know, with the reaction and all of that. So that's really, you're using the same kind of thing when you do the SPA testing. And so you're looking at it and you're saying, okay, how much coloration did it change? And that gives us an idea. If it's really critical for a patient, then you might wanna do a little bit more precise testing. But if you just need it, you know, are we close, then you could use something like that. For a urine test, like if, a lot of times you could just use essentially pH paper and test for their urine if you wanted to know what their urine pH was. So yeah, you could test it pretty easily on that.
But urine pH isn't like representative of blood pH?
Correct. I mean, the urine, as the body is trying to compensate and get its pH back into balance, the urine again will have an inverse, an opposite relationship to what the internal environment is trying to do. And so you could see that. But the urine pH is often a little acidic, where the blood pH, because it's getting rid of some metabolites and some hydrogen ions often. But it depends on what it's trying to do. But yeah, the urine pH would not be enough to tell what their internal environment pH is. You could maybe tell if they're way off or something, but it would be better to do blood. And urine pH could be affected temporarily by what food we eat and other things like that. Well, what helps us maintain our pH in a normal homeostatic values? It's usually, well, it's primarily three things. One is our buffer system. We have several buffer systems in the body. Buffers, as you remember, convert strong acids to weak acids and strong bases to weak bases. In other words, they minimize the pH change. So we have a number of buffer systems that are important. These buffer systems, we'll go back to that in a minute, but the major extracellular buffer, in other words, the one in the blood and the interstitial fluid, is the old equation with carbon dioxide and water yields carbonic acid, which dissociates into hydrogen ion and bicarbonate. This system, you remember this, these are reversible. This is carbonic anhydrase as the enzyme. And it's kind of going away in. So we can shuffle that back and forth as needed. The major intracellular buffers, which are inside the cells, are phosphate and proteins. A lot of proteins with their amino acids can either grab hydrogen ions out of solution or put hydrogen ions in solution, depending on the needs. So we have the buffer system. The other way to control acid base is through the kidneys, the renal system, and the urine, and the respiratory system. Before we get to those in more detail, especially the renal system, since that's the chapter we're on, notice that we can gain hydrogen ions from a number of different sources. This is a table from your book. We can gain it from more CO2 driving this reaction to the right. We get more hydrogen ions. Production of non-volatile. Non-volatile means doesn't go in the air. From metabolism of protein and other organic molecules. So, metabolic production of hydrogen ions, essentially. We can gain hydrogen ions if we lose bicarbonate in diarrhea from mostly small intestine, non-gastric fluids, or we can gain hydrogen ions due to loss of bicarbonate in the urine. This is one of the main ways we regulate it. We can lose more, if we have too many hydrogen ions, we can excrete more bicarbonate ion in the urine. How about hydrogen ion loss? Well, again, certain metabolism where you have ions which take the hydrogen ions out of solution. If you lose in vomiting from the stomach mainly, from the hydrochloric acid, loss of hydrogen ions in the urine, that's another way we regulate it, by secreting more hydrogen ions in the urine. And hyperventilation. Hyperventilation, we blow off more CO2, and so we take hydrogen ions out of solution. So there's different ways we can gain or lose hydrogen ions. Essentially, for the kidneys, we can either secrete more hydrogen ions, secrete and excrete, and reabsorb more bicarbonate, or the opposite. We can secrete and excrete more bicarbonate and reabsorb more hydrogen, which, depending on the direction that we want to go to get us back into balance. A lot of this for hydrogen ions is secreted with countercurrent, opposite exchange with sodium ions in either the proximal or the distal concave tubule. We're going to look at how we alter bicarbonate. There's several different mechanisms. Here's the first mechanism. We freely filter bicarbonate. So here it is, filtered in the lumen. There it is. Now let's say we want to reabsorb what is filtered. In the cell, we can use this familiar equation. Here it is, water and carbon dioxide, H2CO3, hydrogen ion, bicarbonate. And the bicarbonate gets reabsorbed into the internal environment, and the hydrogen ion gets secreted. So what we filtered here, this bicarbonate ion up here, we reabsorbed a different one, but we have basically reabsorbed this filtered bicarbonate and got rid of the hydrogen ion. So that's one way that we can reabsorb more bicarbonate and secrete hydrogen ion. Here's another way hydrogen ion can be secreted with hydrogen phosphate, make H2PO4, and we're again secreting and excreting hydrogen, and we're reabsorbing bicarbonate. This, of course, would be done if our pH is too low, these first two. If we need to reabsorb more bicarbonate and secrete more hydrogen ion. Here's another way. You can take the amino acid glutamine and convert it into ammonium ion and secrete it and reabsorb bicarbonate. So those would be acidosis. Now, you would do less of this if you were in alkalosis. So here's your responses to acidosis, and here's your responses to alkalosis. We don't need to get too bogged down in this diagram, but essentially we have different causes for acidosis or alkalosis. Respiratory caused acidosis means our pH is becoming too acidic because of a breathing issue. Essentially, this is usually due to decreasing our ventilation or breathing rate at rest. If we breathe fewer times per minute, instead of 12 to 15, maybe we're breathing only 6 times per minute, we are not exhaling enough carbon dioxide as usual. we build up the CO2, it drives the reaction to the right, and we get more hydrogen ions in solution. Respiratory caused acidosis. Respiratory caused alkalosis would be the opposite. At rest, we're hyperventilating, we're breathing too fast. Panic attack or something, you're breathing too fast. And so you're breathing out too much CO2. And so you're driving your reaction to the left, you're taking hydrogen ions out of solution, and you're making your internal environment too basic, too alkaline. These are respiratory caused changes in pH. In addition to that, we have metabolically caused changes in pH. This is due to a change in our metabolism. For instance, diabetes mellitus can cause metabolic acidosis because we are breaking down a higher proportion of fats. And so we get ketones, ketoacidosis, and we get metabolic acidosis. We can also get metabolic alkalosis if we have a different metabolic problem, for instance. For respiratory acidosis or alkalosis, we can compensate for it by the kidneys and by the buffer systems of the body. Of course, we cannot compensate for it by respiratory means because the respiratory is what is causing the problem. The breathing issue is what's causing the problem. If we have metabolically caused problems, then we can use respiratory compensatory methods, we can use the renal, and we can use the buffers. We can use all three to compensate for it. So for instance, if we had metabolic acidosis, we would want to increase the breathing rate. We would want to increase hydrogen ion secretion and bicarbonate ion reabsorption to try to get us back into homeostasis. If we had metabolic alkalosis, we would want to decrease our breathing rate. We would want to reabsorb more bicarbonate, outlet less bicarbonate, and secrete less hydrogen ions to get us back into balance. And of course, the buffer systems would work automatically on those as well. So basically, all of this table can be summarized all over what we just said. We don't need to get into any deeper than that, I think. A lot of times on a death certificate, it says the patient died of renal failure, kidney failure. This is because when you have other issues, eventually they can cause the kidneys to fail. If you have congestive heart failure, eventually your kidneys are going to fail. If you have diabetes that is unregulated, diabetes mellitus too long, eventually the glomerular filtration barrier is going to be compromised and your kidneys are going to fail. So it's often maybe the ultimate cause of death, but it was due to something else. This is also one of the causes for the needs for renal transplants, kidney transplants. Fortunately, kidney transplants are one of the more common transplants. We have 2 kidneys and you can live with one, so you can do kidney transplants a little more easily. There's a greater supply, let's say. Transplants of the cornea are more common than kidney transplants, but kidney transplants are pretty common. What other causes of kidney problems do we have? Of course, we're going to have problems if you have hypertension too long, diabetes too long. That's these here. Hypertension, will break down your filtration barrier over time. Diabetes will mess up the endothelial lining of your blood vessels, including your glomeruli capillaries, and that will cause the problem. Bacterial infections can also mess with your filtration barrier. You don't need to memorize this, but this is just a quick picture of a normal glomerulus to your left and an abnormal with a patient with diabetes on your right. I know the clock, so let me just go real. Normally, we need at least 400 milliliters of output of urine a day to maintain body homeostasis. If you have less than 50, your kidneys will start to shut down. That's not enough perfusion. And so this would be anuria, lack of urine, essentially, if you're 50 milliliters or less a day. If the kidneys are failing, a number of patients are on dialysis, where you take some blood out, you put it through a filter system, dialysis, and then you put it back in. And so you might have to have dialysis 2 or 3 times a week. So it's essentially an artificial kidney. It's taking over the role. Of course, it's not as good as our normal kidney, but it can keep the patient alive for some years even, oftentimes. So that's what that's about. All right, so rush there a little at the end, didn't we? So tomorrow and the next 3 days, we'll go over the last chapter, which is reproduction.